Welcome everyone to our first talk of the new year and our fourth talk of the current series. My name is Julia DiPieri and I'm a second year medical student at the UBC Vancouver campus. And today we'll be looking into a variety of common medications that older adults may use and learning about how they actually work. So it would be impossible to cover every medication or even every class of medication. But hopefully this talk will help you understand a bit more about how some of the more common medications do work. And so as always, I'd like to begin with a territorial acknowledgement, both for Vancouver and for Victoria, since I know most of you are joining from there. So I'd like to begin by acknowledging that I'm joining you from the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I'd also like to acknowledge the Lekwungen peoples on whose traditional territory the University of Victoria stands, and the Songhees, Esquimalt, and Wasanich peoples whose historical relationships with the land continue to this day. So, and the usual disclosure statements. So I am a medical student and these talks don't constitute or substitute for medical advice. And there are an infinite amount of medications and a variety of factors that will dictate which one you are prescribed. And I may not necessarily cover those factors today. And our understanding and use of medication as a whole is constantly changing and new medications are coming to market every single day. And on top of that, what's correct today might not even be correct tomorrow. But I did do my best to include a variety of different medications. And please do consult with your healthcare provider or pharmacist if you ever have any questions about your specific health situation. And just a reminder for today, so this talk will likely be around an hour and a half long. If you ever have any questions, feel free to just put them into the chat function, or there will be a 10-minute intermission halfway through, as well as time for questions at the end. So feel free to unmute at that point. But for the rest of the talk, please do your best to keep your microphone muted. And as usual, we will be recording these talks. So if you have to leave at a certain point, or if you'd like to refer back, the link to where the talks will be posted is in the email that I sent initially. All right, so let's get started because we have a lot to cover today and it will be a fairly dense talk, but hopefully you'll be able to get something out of it. So I'll start off by talking about some very common over-the-counter medications that you can buy without a prescription. I'll then move into some more cardiovascular medications, which will include hypertension medications, cholesterol medications, as well as more anticoagulants or blood thinners. And then I'll talk about some various diabetes medications, some thyroid medications, some medications for acid, so proton pump inhibitors, as well as some antidepressants and bisphosphonates, which are for osteoporosis. I have decided not to talk about more strong pain medications and antibiotics. I just thought I'd put that out there because these can be quite complex and I don't really have enough time to get into those today. But I will give you some links at the end if you're ever curious and want to look that up for yourself. And as well, there are several names for a given medication. So I'll introduce each one as the generic version. And if I found that the brand name is used more frequently as well, I'll include that as well. And so within each drug class, there are usually multiple slightly different medications. Therefore, I won't be able to mention every single one, but I will do my best to use the ones that are to include the ones that are most common or most commonly used in Canada as well. All right, so let's start off with over-the-counter medications. So this is any medication that you can buy at the pharmacy without a prescription. And chances are you've all used some of these at some point in your life. And so we'll talk about anti-inflammatories such as ibuprofen and naproxen. We'll talk about acetaminophen or Tylenol, as well as some allergy medications, antacids, laxatives, antidiarrheals, as well as hydrocortisone creams. So non-steroidal anti-inflammatories, or NSAIDs for short, are an extremely commonly used over-the-counter medication. So this includes medications such as ibuprofen with brand names such as Motrin or Advil, as well as naproxen, which is commonly referred to as Aleve, and acetylsalicylic acid or ASA, also known as aspirin. And I will talk about I will talk more about aspirin in a different section of the talk, as it's more commonly used as an antiplatelet agent. And it should also be noted that there are several types of NSAIDs that are more potent and require a prescription, but I won't get into those today. So there are many different types of reasons why you might use some NSAIDs, many of which overlap with Tylenol. So this can include headache, aches and pains, cramps, arthritis, fever, inflammation, and lots of other different things. And it essentially works by inhibiting two enzymes called COX-1 and COX-2. These enzymes are responsible for producing prostaglandins, and these go on to cause pain and inflammation as well as fever. So by inhibiting these medications, this leads to reduced prostaglandins and reduced pain, inflammation, and fever. And so these enzymes are found all over the body, which is why it's an effective general pain and inflammation reducer. It should be noted, though, that prostaglandins are not all bad, and they do have some very important functions, especially when it comes to kidney health, platelet function, and protecting the mucosal lining of the stomach. So I'll get more into the kidney issues that can potentially arise in my next talk on drug interactions. But NSAIDs in particular, especially naproxen, which is a little bit more, it likes to target the GI tract a little bit more. And these can be quite detrimental to the stomach lining if they're used for a very long period of time, and can unfortunately lead to things like ulcers, or potentially worsen ulcers and cause some bleeding as well. Acetaminophen is another extremely commonly used medication, also known as Tylenol, and in the UK or Australia, it's called paracetamol. It's commonly used for treating fever, pain, and headache. So interestingly enough, despite its widespread use, the exact way that it works isn't actually fully known. So it's thought that similarly to the anti-inflammatories, it does inhibit the COX pathway, and it's thought to be a little bit more selective for the central nervous system, which includes the brain. So this would explain why it might be a bit more effective for things like headaches and fever, because obviously headaches are directly related to the brain, and fevers are ultimately controlled by the brain. But that being said, it doesn't help with inflammation as much as NSAIDs do. So if you're having issues with inflammation, typically anti-inflammatories are a little bit more effective. Now, it should be also noted that Tylenol does have some long-term issues as well if used for a very long period of time. And these main detrimental effects are more so for the liver. So if you ever have any liver issues, it's important to talk to your healthcare provider before using Tylenol. If any of you are allergy sufferers like me, you'll be very familiar with antihistamines. So diphenhydramine, or Benadryl, is considered a first-generation antihistamine and is actually used for a variety of different things besides allergies. So this can include things like insomnia, the common cold, and interestingly enough, it's very effective for tremors and things like Parkinson's, as well as nausea and vertigo. And so it works by blocking the histamine receptors. And this blocking of the action of histamine, which is a compound that's central to the immune allergic response, these receptors are all located all over the body, including in the cardiovascular and respiratory system, the GI tract, blood vessels, in the brain, and in immune system as well. So by blocking these receptors, histamine can't go on to produce an allergic reaction and can't activate the immune system, thereby preventing allergy symptoms. And this also helps to prevent constriction of the bronchi, which are one of the two main tubes in the respiratory system that can constrict and unfortunately lead to lack of oxygen, which is one of the ways that people can die from allergic reactions. And it also prevents vasodilation, or widening of the blood vessels, which can lead to low blood pressure and is one of the main symptoms of severe allergic reactions as well. So unlike second-generation antihistamines, Benadryl can cross the blood-brain barrier and also exert its effects in the brain. And this leads to drowsiness to the point that you shouldn't actually be operating a vehicle. This is one of the main downfalls of it as an allergy medication on its own, but something that definitely makes it more appealing to use in the setting of insomnia, for example. So it also suppresses the cough center in the brain, which helps with cold symptoms as well. And that leads us into our first poll question, which is which of the following medications actually contain Benadryl. So we have loratadine or Claritin, which is another allergy medication, diamondhydrate or Gravel, which is an anti-nausea medication, loperamide or Imodium, which is an antidiarrheal. And then our last option is a medication and a medication that's not possible. Just let a few more people respond and then I'll show the answers. Okay, so I'm going to end the poll. I'll share with you the results. So a lot of you, the majority of you got it right. So the answer is diamondhydrate or Gravel, which I know it can be confusing to think that another allergy medication such as Claritin wouldn't contain Benadryl, but I'll explain shortly why that is. And if you want to get rid of the poll in front of your screen, you just have to exit it out. It's in the top left-hand corner. So you might be interested to know that Gravel or diamondhydrate is also a first-generation antihistamine. So diamondhydrate is actually a combination of diphenhydramine or Benadryl and another compound such as a stimulant. So similar to Benadryl, it does block the histamine receptors in various areas such as the GI tract, the blood vessels, and the respiratory tract. And it also decreases stimulation of the vestibular system, which is the system often associated with your inner ear and balance. And a big reason why we get motion sickness is due to our vestibular system getting a little bit mixed up. So if your head's bobbing around like this, it can really get the inner ear a little bit confused. And that's how you lead to motion sickness and nausea and vomiting. And then therefore, this is how this medication helps reduce that. Similar to Benadryl, you also get the drowsy effect, but not as much due to the fact that that other compound that it's mixed with is a stimulant. So it does help to ward off some of those symptoms. But it's good to know that if the only medication you had was Gravel and you were having some allergy symptoms, this might help a little bit. Now into the second generation of antihistamines, such as loratadine, Claritin, cetirizine, or Reactin, Diuretics, and fexofenadine or Allegra, and there's many others, but those are the ones I just mentioned. And they work slightly different than Benadryl. So one of the big appeals of these medications is that you don't have that drowsiness effect that you get with Benadryl. And this can be explained through the different mechanism of action. So the big difference here is that they're a bit more selective, meaning that they only block certain histamine receptors, but not all of them. So similar to Benadryl, it blocks the histamine receptors in the respiratory system, the blood vessels, the GI tract, and immune cells, but it doesn't have the ability to cross into the brain. And this is why these medications are actually non-drowsy, is because of that blocked effect. And that's why they're a bit more appealing solely for treating allergy symptoms. So antacids include things such as calcium carbonate, also referred to as Tums or Alka-Seltzer tablets, as well as magnesium hydroxide or milk of magnesia, and Gaviscon is another antacid. And so in the context of being an antacid, these are often used in the setting of excess acid production, which would result in symptoms such as heartburn or acid reflux, which may also be associated with gastric ulcers or potentially biliary reflux. And they can also help with stomach upset and nausea. So calcium carbonate in particular can also be used as a calcium supplement because calcium is part of that medication. And people with low calcium or in the setting of chronic kidney disease can also be used as a way of lowering phosphate, since calcium will bind and remove phosphate from the system. So antacids work by neutralizing existing stomach acid. So it doesn't have any effect on the production of stomach acid, and I'll talk about a medication that does have an effect on that later on. If you think back to your high school biology and chemistry classes, you might remember that the stomach is a naturally very acidic environment with an abundance of protons and a pH of 2. When antacids such as calcium carbonate are consumed, the calcium ion dissociates from the carbonate, which allows those protons to be bound instead. And this removes the protons and reduces the acidity of the stomach, as well as the symptoms that can occur when there's too much acid. So essentially, you're just neutralizing the acid. The free calcium can then go on to stimulate the rhythmic contractions of the GI tract, which can also help to move the acid that may have landed in the esophagus back into the stomach. And similarly, magnesium hydroxide or milk of magnesia works very similarly, although you don't have that calcium supplementation with that. Gaviscon works a little bit differently, and it works by creating a protective layer over the stomach contents. So it's almost like a net. And this prevents acid from escaping into the esophagus, basically. Moving into antidiarrheal medications. So this can include loperamide, aka Imodium, as well as bismuth subsalicylate, aka Pepto-Bismol. So you might be interested to know that Imodium actually acts like an opioid, and it works by binding opioid receptors in the intestines to reduce peristalsis, which is the rhythmic movement of the intestinal muscles that pushes contents along. This allows for an increased time that the contents are in the intestinal system, and this allows more water to be absorbed out of the stool. And this reduces diarrhea because diarrhea is very, very liquidy, watery stool oftentimes. At low doses, aka the doses that are in the form that you buy at the drugstore, you don't get any of those central opioid-like euphoric effects. However, if you were to consume, say, 20, 30, 40 of these all at once, it could cross the blood-brain barrier and cause the opioid euphoria type symptoms because of that binding of those opioid receptors. So unfortunately, Imodium has become a medication that is unfortunately abused in people who have substance use issues. Pepto-Bismol, on the other hand, is a bit more complicated. So in the stomach, the compounds bismuth and salicylic acid separate. So bismuth combines and forms a salt-type compound, which has antimicrobial properties, which is why it can be particularly helpful if you have something like traveler's diarrhea, where an infection is likely involved, or alongside other medications when a bacteria called H. pylori is involved. And H. pylori is the bacteria that causes stomach ulcers. Now, Pepto-Bismol also helps to cover any ulcers that are already present, basically creating kind of like a mucus type layer. And this prevents any further damage or erosion due to the acidity of the stomach. And this helps to reduce inflammation and irritation, as well as more prostaglandin formation, which is also responsible for more inflammation and motility or movement of the stomach. On top of that, it also stimulates reabsorption of fluids and salts from the intestines, and this also helps to reduce fluid in the stool, and this makes it less liquid. So Pepto-Bismol definitely has multiple different qualities that make it an effective antidiarrheal medication. On the opposite end of the spectrum, we have laxatives. So this can include bulk fiber supplements, such as with Metamucil. There's also oral stimulants, such as bisacodyl or Dulcolax or senaglycoside or Senecot. And there are other categories as well as such as oral osmotics and oral stool softeners, but I won't mention those today. And so these are all generally used in the treatment of constipation, and constipation occurs as a result of there not being enough fluid in the stool. Or it can also occur due to reduced peristalsis from the GI tract, which is when it's not moving as much, or potentially things like not enough fiber as well. So oral bulk formers, such as Metamucil, work to help draw water back into the GI tract. And this makes it easier for the GI tract and the stool to move along. This is also why fiber in general is recommended as part of your diet, but this is essentially just a higher concentration of fiber. So constipation, think of it like like your stool is like a dry sponge. It's really hard to move a dry sponge along a surface, but if you get some water into that sponge, it's going to be a lot easier. So that's essentially how this medication works. Oral stimulants such as Dulcolax or Senecot work by stimulating the nerves along the GI tract, and this increases peristalsis, or those rhythmic contractions of the intestinal muscles, in order to move the stool along. And they also prevent reabsorption of water from the bowel, which helps make stool softer as well. Our last over-the-counter medication is hydrocortisone cream. So if you ever had eczema or psoriasis or any other inflammatory skin conditions, you will likely be quite familiar with this medication. And this can come as a prescription form as well, and in higher strengths. But the over-the-counter types typically come in 0.5% or 1% forms. So it's indicated for multiple inflammatory skin conditions such as eczema or psoriasis, like I mentioned. And so inflammation in general occurs in a very long cascade, aka one thing leads to another, and they all kind of feed on to each other to create a really big reaction. So hydrocortisone goes in there and helps interrupt that cascade by releasing inhibitory proteins and reducing the formation of chemical mediators of inflammation, such as histamine and prostaglandins, thereby interrupting that cycle, reducing the inflammation and calming down the skin, essentially. So now we'll be moving on to more the prescription side of medications. And we'll start off with the hypertension medications, because that's probably one of the most common medications that most people here might be using. And there are multiple different categories of hypertension medications. So this can include ACE inhibitors, angiotensin II receptor blockers, or ARBs, a couple different types of diuretics, as well as beta blockers and calcium channel blockers. And some of these medications are used for multiple different purposes, which I will try to mention as well. But the main focus here will be on how they are used to treat hypertension. So I think it's important to understand what types of factors affect hypertension in order to understand how these different medications work, because they ultimately are the different targets of the medications. So blood pressure is determined by the cardiac output, which is the total amount of blood pumped per minute multiplied by the resistance of the vessels. So the concept of resistance is fairly straightforward. The narrower the pipe or the vessel, the more pressure is going to be exerted on the outer walls of the vessels, aka the higher the pressure there will be. So anything that dilates the vessels or makes them bigger will be effective at lowering blood pressure. Cardiac output can also be divided in two ways. It can be modified by stroke volume, which is the amount of blood pumped out per heartbeat, as well as the heart rate, which is the number of beats per minute. If you reduce the amount of blood that's in the circulation, there won't be as much blood to pump, aka there will be less pressure. If you pump the blood less frequently, this will also reduce the strain on the vessels. So you can modify one or more of these three factors in order to reduce blood pressure. So our first class of medications are the ACE inhibitors, and ACE stands for angiotensin converting enzyme. So these are one of the mainstay medications for hypertension, but are also indicated in the prevention and treatment of heart failure and post-heart attacks, or if you have angina as well. So examples in this class include captopril, lisinopril, ramipril, and you'll notice that most of them end with the ending pril. So it makes it a little bit easier to remember. So ACE is part of the renin-angiotensin-aldosterone system, or RAS. And this is a system that's responsible for regulating blood pressure and fluid electrolyte balance. As you can see in this flow diagram in the top right here, the RAS system ultimately leads to two things, and that's vasoconstriction, or reducing the diameter of the vessels, as well as renal sodium retention. And this helps to increase the water that's being, or prevents water from being excreted by increasing blood volume. By inhibiting the ACE enzyme, which works up here through ACE inhibitors, this ends up preventing this whole system from happening. And this allows dilation of the vessels and reduction of the resistance, and also reduces the secretion of another hormone called aldosterone. And that's responsible for sodium retention, and it would end up being right around down here. And overall, this leads to less blood in the circulation and lower blood pressure. So this works in two different areas by reducing stroke volume as well as resistance. So another common medication are the angiotensin II receptor blockers. And these are commonly referred to as ARBs. And these medications have the sartan ending and are also very common, such as irbesartan, losartan, and valsartan. And so similar to ACE inhibitors, they are commonly used for hypertension, as well as heart failure, chronic kidney disease, and have a very similar mechanism. So they act on the RAS system as well, but they just act at a slightly different place. So they end up blocking the angiotensin II receptor, thereby just working at a slightly different place. So some of the reasons why you might use an ARB instead of an ACE inhibitor is a very common side effect of ACE inhibitors is a cough. And unfortunately, that cough just doesn't go away. And that's because of a certain byproduct that ends up, if I remember correctly, the byproduct, I think it's called bradykinin, ends up causing a cough. But with ARBs, that doesn't happen, which is why some people switch. So moving into the diuretics, I know this is a very busy slide, but hopefully it'll help illustrate our next few medications, which can be collectively referred to as diuretics. And their primary goal is to reduce fluid in the circulation as their way of reducing blood pressure. So this is a picture of a nephron, and the nephron is a tiny functional unit that is the filtration center of the kidney, and there are thousands of these within the kidneys. The purpose of the kidneys is to regulate fluid and electrolyte balance, and it's also responsible for concentrating the urine. And if we didn't have this concentration going on, we'd be peeing out liters and liters and liters of fluid every single day. And so it has a variety of ways of regulating fluid and electrolyte balance, one of which is with the RAS system. And it chooses to reabsorb or excrete substances in order to achieve the correct balance. So we'll start off with loop diuretics. So if you've ever watched a medical show, you may have heard of the term Lasix being thrown around. And Lasix is the brand name for furosemide, which is the main loop diuretic that we use. So its main use pertains to what we call fluid overload or edema, where there's just so much fluid going into the tissues that it can lead to swelling in the extremities and severe weight gain. And this can also happen in acute situations such as with sepsis, but also may be used for the treatment of severe heart failure, end-stage kidney disease, especially if hypertension is present alongside of those. So it's not technically a first-line medication for hypertension, and we would rarely use it if you just had hypertension. But if you did have some of these other conditions, then that might be something to use. So it acts in the middle here on the portion of the nephron called the loop of Henle. So the loop of Henle is primarily responsible for reabsorbing water. So as you descend down here, the urine becomes more concentrated and more water is reabsorbed. On the way back up, water can't be reabsorbed anymore. So you can see furosemide is right down here. And that's because there's a specific transporter that moves sodium, potassium, and chloride back into the blood. So what you'll see with a lot of these diuretics is that things like sodium, especially, are a big reason for why water moves to certain places. So water likes to follow salt. So if you're reabsorbing salt back into the blood, water will eventually follow. So furosemide acts by inhibiting this process, thereby leaving the sodium in the urine and not getting it moved into the blood. And as a result of that, the water stays in the urine and gets excreted in the urine. So this diuretic is very effective at getting rid of large volumes of fluid and also helps to dilate veins, which helps to reduce pressure as well. So thiazide diuretics are the next major class and include more common hypertension medications such as hydrochlorothiazide, chlorothiazide, and chlorthalidone. So they are mainly used for hypertension, but can also be used in situations of fluid overload or edema as well, such as with heart failure and cirrhosis. It works on a slightly different part of the nephron called the distal convoluted tubule. So this pink part right here, and you can see thiazides are inhibiting a certain process here. So in that area, there's another sodium chloride channel that reabsorbs salt back into the blood. And as we know, water likes to follow that. So thiazides work by blocking that channel, keeping the sodium in the urine and keeping water in the urine, thereby reducing the blood volume. And it also helps to dilate arterioles, which are small arteries. So that helps to reduce resistance as well. Last of the diuretics are the potassium-sparing diuretics, which include spironolactone, eplerenone, and amiloride. So indications include hypertension, heart failure, edema or swelling, cirrhosis, and some other conditions. Usually it won't be the first choice for hypertension as well, but it will be added onto existing medications if your blood pressure is not going down, or in situations where you have low potassium. And so these medications act the furthest along the nephron in the distal tubules, as well as the collecting duct. And it opposes the action of aldosterone, which you might remember from before, is a hormone that works on these tubules and the collecting duct. And aldosterone is a hormone that's responsible for reabsorbing sodium, and in turn, reabsorbing water to maintain blood pressure and fluid balance. And since we don't want that in hypertension, we don't want that extra volume, this inhibits the actions of this hormone, and this causes sodium to be excreted in the urine as well as water to reduce the fluid volume. So you might be wondering why they're considered potassium sparing if they're getting rid of sodium, and that's because of the transporter that it acts on. So essentially the transporter exchanges sodium in turn for potassium, so they're going different ways, which allows potassium to be retained within the blood. Many of the other hypertension medications work on transporters that have sodium and potassium going the same way. And so therefore, complications of those medications can be low potassium, which can be life-threatening if it gets too low. So if you have other medications that are causing low potassium, this brand of medication can help retain some of that potassium by keeping it in the blood. Calcium channel blockers are a bit more broad in their use, but they're nice in the way that if you have two issues going on at once, so a cardiovascular issue as well as hypertension, for example, then you can basically hit two birds with one stone. And they include verapamil, diltiazem, amlodipine, nifedipine, and felodipine. And they help with hypertension, angina, abnormal cardiac rhythms or arrhythmias, as well as pulmonary hypertension, which is elevated pressure in the lungs, as well as other cardiac problems. So overall, calcium channel blockers block the inward movement or slow the inward movement of calcium into the cells in the heart, smooth muscle, as well as the pancreas. So without the movement of calcium moving into the cells, the heart could not contract properly. And so there's technically two subclasses within this one class. So it's important to distinguish them slightly because their properties and functions are slightly different. So in one class, we have the non-dihydropyridines. So that includes verapamil and diltiazem. And they're a bit more specific for the heart. So they target the heart a little bit better. And they work by slowing the speed that the heart contracts by slowing down the electrical signal that's needed to activate the heart muscle. As a result, the heart doesn't contract as fast or as forcefully. And this really helps reduce the strain on the heart and also reduces the oxygen demand a bit as well, which is very helpful in things like angina. It also helps to reduce blood pressure by lowering the heart rate, as well as controlling any abnormal rhythms. Therefore, these medications are good for people who have a concurrent cardiac problem alongside hypertension. On the other hand, the dihydropyridines are slightly different, and they include amlodipine and nifedipine. And they act a bit more peripherally on the blood vessels and help to vasodilate the blood vessels and reduce the resistance. And therefore, these are a bit more specific for things like hypertension, for example. So beta blockers are our last class of hypertension medications and are pretty much a mainstay when it comes to treating cardiac disease. And they have the ending lol, and some examples include propranolol, labetalol, and metoprolol, among many others. Aside from hypertension, they can be used to treat abnormal rhythms or extremely fast heart rates, as well as things like heart failure and many other cardiac diseases. So the mechanism is in the name here, in that they block the actions of epinephrine and norepinephrine on the beta receptors. So epinephrine and norepinephrine are both considered excitatory hormones or neurotransmitters, and generally lead to the activation of the sympathetic nervous system, or the fight or flight nervous system, which one of the byproducts of that is that your heart rate is increased. So by blocking these receptors, this leads to a decreased heart rate and also decreases the secretion of a hormone called renin, which through a long cascade incorporates into the renin, angiotensin, aldosterone system, and therefore also reduces blood pressure through lower stroke volume. So moving into statins. So statins aren't technically a hypertensive medication, but I didn't really know where else to put it, so here it is. So chances are if you have hypertension, you'll also be on a statin. So statins include things like atorvastatin or Lipitor, as well as rosuvastatin or Crestor. And these are one of the most commonly prescribed medications in Canada. And they are indicated primarily for preventing coronary artery disease and therefore preventing heart attacks and strokes. And this is especially true for people who are at risk because they have high cholesterol or high lipids. And they lower cholesterol and lipids by inhibiting an enzyme called HMG-CoA reductase. And this is an enzyme that's present in the liver. Believe it or not, the majority of our cholesterol is actually made by our liver, with only about 25% of the cholesterol in our bodies being from our diet. So by inhibiting this enzyme, the liver is less able to make its own cholesterol. And so we do naturally need cholesterol for a variety of different bodily functions. And so it needs to take it now from somewhere else. And it does this by upregulating low density lipoprotein receptors, or LDL receptors, on the liver cells. And you might have heard of LDL if you've ever had a blood test for your lipids. That's what it's commonly referred to. As a result of these upregulated receptors, the liver is able to take low density lipoproteins, which carry a ton of cholesterol throughout the body, and so that it can now be used for its various functions. As a result of this, you have less lipoproteins floating around, and these lipoproteins unfortunately contribute to the formation of plaques in the arteries, which can eventually lead to coronary artery disease, heart attack, and stroke. So as a result of that, then you get lower cholesterol, and then you don't get a buildup of that plaque in the arteries. That'll move on to our next poll question, which is which of these medications was originally invented to treat hypertension until they realized it actually had very useful side effects somewhere else. So there's levothyroxine, which is for low thyroid, sildenafil or Viagra, as well as benzodiazepines, which are used for anxiety and seizures, and bisphosphonates, which are used for osteoporosis. I'll just let a few more people answer. All right, so on the poll, so majority of you got it right again. Great. So the correct answer is sildenafil, or Viagra, was originally designed to treat hypertension. So now you know something new. So we'll talk about that. So as we just learned, this class of drugs was discovered by accident. So they were actually trying to treat hypertension and angina symptoms. So the phosphodiesterase 5 inhibitors, or PDE5 inhibitors, include Pfizer's original claim to fame, Viagra or sildenafil, and tadalafil and Cialis are from a different company. But they are primarily now used for the treatment of erectile dysfunction, as we all know, as well as prostate enlargement and pulmonary hypertension, which is when the pressure in the lungs are too high. And they work by inhibiting the enzyme phosphodiesterase 5, which is present in smooth muscle cells. Smooth muscle is a big component of blood vessels, especially arteries, and help control the diameter and the flow of the vessels. So during a sexual experience, after receiving the appropriate inputs from the brain, nitric oxide is released, which causes vasodilation or widening of the arteries. So PDE5 inhibitors prevent the breakdown of the end product of this cascade and therefore allow that vasodilation to be sustained for longer, therefore helping treat erectile dysfunction. If you recall back to the other medications, you can understand why they thought this might be helpful for hypertension, since vasodilation helps to reduce blood pressure. It just turned out that these medications were a bit more specific in their choice of location. And this is our last one before our break. But also on the topic of vasodilation, we have nitroglycerin. So its main indications are for anginal chest pain, which is usually secondary to coronary artery disease or buildup of plaque within the coronary arteries. And nitroglycerin is a precursor to nitric oxide. And when I mentioned, which I mentioned is an important vasodilator in the blood vessels. So through a long cascade, nitric oxide leads to relaxation of that smooth muscle within the blood vessels and helps reduce the symptoms of chest pain. And this is especially true in the veins, which helps also decrease the oxygen demand on the heart. It also helps to reduce pain. All right, so that brings us to our intermission. So we will take a break for about 10 minutes. And when we come back, I can answer any questions that might be in the chat. Yeah, thank you so much, and we'll see you in 10 minutes. Yeah, so I did mention it briefly, but ACE inhibitors, unfortunately, are notoriously known for producing a dry cough in close to like a third of people that go on to them. And this is because of a metabolite called bradykinin that ends up accumulating, which ACE inhibitors unfortunately inhibit the metabolism of bradykinin. And then that can be quite irritating and stimulate histamine receptors. And that's how the cough ends up happening. So it's a very common side effect. Are there any other questions? I don't believe hydrochlorothiazide is a huge contributor to cough. It is mainly the ACE inhibitors, which do end in pril, like Dr. Gair mentioned. Okay, if there's no other questions in the chat, we can keep going. So for the last part of our talk, we'll talk about a variety of blood thinners or anti-clotting agents, as well as diabetes medications, a thyroid medication, medications for acid reflux, as well as antidepressants. So there's a variety of different blood thinners that we can use, and we can use them in different clinical scenarios. So I'm sure everyone is quite familiar with aspirin, but we'll talk about some other antiplatelet agents, as well as warfarin, direct anticoagulants, and heparin. So acetylsalicylic acid, commonly referred to as ASA or aspirin, is actually a non-steroidal anti-inflammatory and can be purchased over the counter. It has a variety of things it can treat and is often used for cardiovascular conditions such as angina, heart attacks, and after procedures such as stenting. And it can also be used for fever, pain, and arthritis in higher doses. So you may recall from the beginning of the talk that the COX-1 and 2 enzymes were important with anti-inflammatories and were blocked, thereby reducing inflammation, pain, and fever. And aspirin does this as well, and this is how it reduces inflammation, pain, and fever. This also feeds into the clotting cascade, and it inhibits formation of a compound called thromboxane A2. And this helps to prevent platelets from aggregating or bunching up, and therefore this prevents a clot from forming. That being said, it is important to note that while aspirin can be effective at preventing certain cardiovascular events, such as heart attacks, it does come with a risk of bleeding, and therefore shouldn't be taken without guidance from your healthcare provider. So they're not something that you can just go on without thinking. There are some risks that come with it. So antiplatelets are technically called P2Y12 inhibitors, which are lovely names. And this includes clopidogrel or Plavix, prasugrel or Effient, and ticagrelor or Brilinta. And they are used in the treatment of unstable angina, heart attacks, as well as prevention of recurrent heart attacks and strokes. And they are typically part of antiplatelet therapy after receiving a stent, which you will likely receive as part of heart attack treatment, or if it's found that your coronary vessels are quite blocked. Similar to aspirin, they prevent platelet aggregation or clumping to form a clot by inhibiting a different receptor on the platelets called the ADP receptor. And so when it comes to stents, they're often used alongside aspirin for maximal efficacy. And just a reminder, in our blood, we've got 3 main types of cells, majority of which are red blood cells, and you also have some white blood cells. So all of these little round things are red blood cells. This is a big white blood cell in the middle here. And these little bits here are technically fragments of white blood cells, and those are the platelets. And platelets are responsible for clotting the blood in the event of an injury to the vessel or the skin, and are unfortunately typically involved in things that are pathological, such as clots in the heart and the brain. So direct oral anticoagulants, or DOAGs, are a bit more powerful than these other medications I've mentioned. And this includes rivaroxaban, apixaban, as well as edoxaban and dabigatran. So rivaroxaban and apixaban are the most commonly ones that we use, especially in Canada. And they're often used for prophylaxis or prevention of clots. And this may include after major knee or hip surgery, where you know you're going to be immobilized for a long time or in hospital, and that can predispose you to developing clots. It's also used for atrial fibrillation due to the risk of clots and strokes, as well as deep vein thrombosis and pulmonary embolism, which are clots in the deep veins of the legs and the lungs, respectively. And so these all work by inhibiting certain factors in the clotting cascade, and there's a very, very long cascade that occurs. So rivaroxaban, apixaban, and edoxaban inhibit factor 10A, which is a little bit higher up in the clotting cascade, while dabigatran inhibits thrombin, or factor 2A. By disrupting the clotting cycle, the initial platelet plug that needs to form to create a clot can't form, and this essentially prevents clots from forming and helps to prevent them from going elsewhere. Next up, we have Warfarin, or Coumadin, which is significantly older but also cheaper than the direct oral anticoagulants. So Warfarin is essentially used for the exact same things as the direct oral anticoagulants, such as deep vein thrombosis and pulmonary embolism, atrial fibrillation, recurrent heart attacks and strokes, and things like that. So oftentimes DOAGs, or the direct oral anticoagulants, are preferred since there is much less monitoring and a lot fewer interactions with other medications on the patient end. But the big benefit of Warfarin is that it's extremely cheap. So that does make it a lot more appealing to most people. And it works slightly different. And this is kind of like the bigger clotting cascade that I was talking about. It inhibits the vitamin K reductase enzyme, which is responsible for activating vitamin K. By inhibiting this enzyme, Warfarin inhibits clotting factors 10, 9, 7, and thrombin, or 2, as well as some other proteins. So that's why if you're on Warfarin, you'll often be told to avoid foods with vitamin K, because otherwise you're essentially deactivating the effects of Warfarin. So in comparison, Warfarin is acting a little bit more on various factors over here, whereas the oral anticoagulants are mainly just looking at these two. So heparin is a broad class, and so the examples I've mentioned here, such as dalteparin and enoxaparin, are considered to be low molecular weight heparin, and are the ones that are typically most commonly used and interchanged with warfarin and DOACs as well. So low molecular weight heparin is particularly helpful in patients who are pregnant, because warfarin is completely contraindicated in pregnancy, meaning that it could potentially cause birth defects. And the DOACs are newer, so there isn't as much data in that front. So typically we'll just use this type of heparin just because we know that it's safe. There's also regular IV heparin as well as unfractionated heparin, but typically we won't use these types as often due to there is a rare risk of what's called heparin-induced thrombocytopenia. So if you remember a big issue with the AstraZeneca vaccine with the rare blood clots, this is a very similar condition that can occur if you use heparin, but extremely rare, and it's still a very safe drug to use if that's all you have. So heparin works slightly different. It inhibits an enzyme called antithrombin, which goes on to inhibit factors 10A and thrombin as well, and this helps to prevent clotting. So as you can see, this whole thing is quite complicated, but our direct oral anticoagulants are here. Heparin works slightly different over here, and warfarin is up here, and eventually it just leads to a big clot. So next we'll talk about diabetes medications. So there are way too many classes of diabetes medications in my opinion, but I have selected a few to talk about today. And this includes insulin, biguanides or metformin, GLP-1 receptor agonists, DPP-4 inhibitors, SGLT2 inhibitors, as well as sulfonylureas. And just a reminder about most of these treat type 2 diabetes because that's the main focus of our next medications. So glucose or sugar is another compound that the body really likes to maintain at a certain level. So after a meal, your glucose naturally increases due to the breakdown of the compounds in your food. And as a result of that, the pancreas releases insulin. And this is to decrease the blood glucose down to normal levels. And it does this by increasing the availability of transporters to move glucose into the tissues. And this specifically happens in the liver, the skeletal muscle, or the general muscles everywhere in your body, as well as adipose or fat tissue. And this is typically used for energy or fuel or energy storage as well. Glucagon is a hormone that does the exact opposite. And so if your blood sugars are sent to be too low, say after a long period without food or during the night, the pancreas will release glucagon to try and stimulate release of glucose into the blood. And this is primarily done in the liver over here. So in type 2 diabetes, this whole process doesn't work very well. And as a result, you end up with a higher than normal blood sugar level and often decreased sensitivity of the tissues to insulin. And this ultimately results in those higher blood sugar levels. And so this will be our last poll question here. But which of the following medications was actually discovered in Canada? So we've got SGLT2 inhibitors or canagliflozin, insulin, DPP-4 inhibitors, or dulaglutide, or we don't invent things in Canada. Just give it a few more seconds. Okay. So again, the majority of you got it right. Frederick Banting did find or discovered insulin, which before that diabetes was essentially a death sentence. So we're very thankful that that was discovered. So insulin is exactly what it says it is. It's the man-made version of human insulin. And it's used from the get-go in type 1 diabetes, since the body is unable to produce insulin in that condition. And depending on a patient's ability to control their sugars or whether they're starting to have downstream complications of diabetes, such as nerve damage or retinal damage in the eyes, then that might be when we start to use it for type 2 diabetes. But generally speaking, we will try to use some of the other medications for type 2 diabetes before adding insulin, since there's a lot of work on the patient's end in order to measure out the correct amount of insulin, but not too much to the point of hypoglycemia or low blood sugar, which can be life-threatening. So there's several types of insulins, some of which are considered short-acting or termed bolus insulins. And these are typically given before a meal in order to reduce the sugars that are going to be generated from that meal. So this can include Aspart or Novolog or Lispro or Humalog. There's multiple different types. There are also long-acting insulins or basal insulins, and these are meant to prevent blood sugar fluctuations throughout the day. So examples of these include Degludec or Tresiba, and Glargine or Lantus are the most common. And some come in these handy quick pen formats, so you don't have to draw it up yourself, or some just come in the vials like that. So basically the way it works is by acting like your body's own insulin. So following a meal, like we said, glucose is released into your bloodstream and your body doesn't like this. So it releases insulin from the pancreas, and that ultimately stimulates cells to take up glucose from the blood in order to be used for energy. And this lowers your blood sugar. Probably the most common diabetes medication is Metformin, which is a type of biguanide. And it's primarily used in the treatment of type 2 diabetes, especially early on, as well as for the treatment of pre-diabetes, aka when your blood sugars are higher than normal and have the potential of progressing to type 2 diabetes, but they're not quite there yet. It can also be used in gestational diabetes, which is diabetes that develops during pregnancy, as well as with polycystic ovary syndrome, or PCOS, as one of the symptoms of that can be elevated blood sugars. So it reduces blood sugar in a few different ways, one of which is by decreasing glucose production in the liver. Another is by decreasing the ability of the intestines to absorb glucose after a meal. Therefore, you just end up excreting glucose in the stool. And it also helps increase insulin sensitivity and glucose uptake in the tissues. So it works in a variety of different ways here. GLP-1 receptor agonists, or glucagon-like peptide-1 receptor agonists, are another class of commonly used medications. And these include dulaglutide or Trulicity, liraglutide or Victoza, and semaglutide or Ozempic. And these are used for treating type 2 diabetes only. And liraglutide in particular has been approved for the treatment of obesity to help with weight loss. And you'll see why. This medication binds GLP-1 receptors, and GLP-1 is a hormone whose effects are often blunted or absent in type 2 diabetes. By stimulating this receptor, the downstream effects of GLP-1 are restored, and this ends up reducing glucose in a couple different ways. So one way is by stimulating insulin release after a meal, which obviously, as we know, helps to lower sugars down to normal levels. It also inhibits the release of glucagon if blood sugar is too high. And as we said, that hormone is responsible for raising blood sugar when it's too low. But in diabetes, obviously that process is a little bit off. It also helps prevent cell death of beta cells in the pancreas, and those are the cells that are responsible for producing insulin. And this helps to preserve the body's ability to make its own insulin for longer, since these cells, along with other cells, can die if blood sugar is too high for long periods of time. It also helps to slow stomach emptying, meaning that people feel fuller for longer and they don't eat as much or as often. And that's how it helps with weight loss, particularly. So DPP-4 inhibitors are quite similar to GLP-1 receptor agonists, and they're used in the treatment of type 2 diabetes only. And this includes linagliptin, saxagliptin, and sitagliptin. So DPP4 is an enzyme that acts on a group of hormones called incretins, one of which is GLP-1, which we just talked about. So under normal circumstances, DPP4 will degrade GLP-1 in order to maintain the normal levels of glucose. And as I mentioned in the last slide, we want those effects of GLP-1 in type 2 diabetes because they help with problems of low insulin secretion, inappropriate glucagon release, and also help preserve the pancreas. So essentially, by inhibiting the enzyme that would reduce the effects of GLP-1, we essentially get the same result as the GLP-1 receptor agonists. So our next class of medications are the SGLT2 inhibitors, and this includes canagliflozin, dapagliflozin, and empagliflozin. So these are sometimes referred to as the P pills, and you'll see why shortly. And they are indicated for type 2 diabetes, and they are a newer class of drug. So several studies have been looking at the longer term impacts. And in general, one downstream issue of diabetes in general is cardiovascular disease. So you have a higher risk for heart attack and stroke, and therefore death from those things. So the newer trials that have been coming out have shown that this class of medications in particular has had actually quite a positive benefit for cardiovascular health and has overall reduced mortality from cardiac causes. And these medications work primarily on the kidneys, and these inhibit the sodium glucose cotransporter 2 channel. So that's what SGLT2 stands for. So normally these channels help reabsorb glucose that may be filtered out of the blood and into the urine in order to maintain appropriate glucose levels. Since we know that this process doesn't happen well in diabetes, inhibiting these transporters helps prevent glucose from being reabsorbed into the blood and is instead lost in the urine. Therefore, as a result, since sodium is going the same way as glucose in this transporter, we lose some sodium as well. And if we remember back to our hypertension medications, water likes to follow sodium and glucose. We also lose some water, which is why they're sometimes called P pills, because you're essentially peeing out the glucose. This also may be why they have a cardiovascular benefit due to reductions in sodium and therefore reductions in blood pressure. Sulfonylureas are the oldest class of anti-diabetic medications, aside from insulin, and they came to market in the 1950s. And so they include glimepiride, glyburide, and glipizide, and they're only indicated for type 2 diabetes as well. And they act directly on the pancreas and the pancreatic beta cells, which, as I said, these are the cells that produce insulin. Through a very long cascade, they eventually stimulate the pancreas to make more of its own insulin, regardless of the blood glucose levels. They also decrease the liver's ability to metabolize insulin, which leads to a prolonged effect, as well as decreased glucagon secretion and increased sensitivity to insulin in other tissues. Okay, so that wraps up diabetes. So these are a few random medications that I thought were quite common, but there weren't enough classes to make their own slide for them. So we'll talk about levothyroxine, proton pump inhibitors, antidepressants, and bisphosphonates to finish. So levothyroxine, also known as Synthroid, is another very common medication in older age. And it's indicated for hypothyroidism, which is when the thyroid gland doesn't produce enough thyroid hormones. And these are very important for a variety of bodily functions, especially metabolism. So hypothyroidism may be due to a problem with the thyroid gland itself, such as with Hashimoto's thyroiditis. It's kind of like an autoimmune type of thyroid disease, or it may be due to issues with the pituitary gland in the brain. And this is responsible for secreting thyroid stimulating hormone, which ultimately stimulates the thyroid to produce thyroid hormones. So levothyroxine is a synthetic version of T4 or thyroxine, which is one of two thyroid hormones the thyroid secretes. And ultimately T3 is the other one, but T4 is eventually converted to T3, so it ends up supplementing both of those. Proton pump inhibitors, or PPIs for short, are a class of medication that work on the stomach and include omeprazole, pantoprazole, and rabeprazole, and they're indicated for a wide variety of stomach issues related to excess stomach acid production, such as peptic and duodenal ulcers, which can be caused by H. pylori infection, and that's a common bacterial infection in the stomach. It's most commonly used for gastroesophageal reflux disease, or GERD, and can also be used for heartburn and other esophageal issues. So as I mentioned with the antacids before, the stomach is a naturally very acidic environment with the pH of 2. And although usually the stomach is very well suited to tolerate that acidic environment, but when something causes acid to leak into the esophagus, such as GERD, or erode some of the protective mucus layer in the stomach, such as with H. pylori, or with anti-inflammatories such as NSAIDs, this can start to cause a lot of problems. So proton pump inhibitors work to decrease the actual acid production in the stomach. And they do so by inhibiting a proton pump, which essentially pumps protons into the stomach, thereby making it more acidic in exchange for a potassium ion. So these medications are more effective than the over-the-counter antacids I mentioned before, since they actually end up reducing the acid secretion in the stomach rather than just neutralizing it temporarily. So moving on to antidepressants. So selective serotonin reuptake inhibitors, or SSRIs for short, are a class of medication used to treat major depressive disorder, as well as several types of anxiety disorders. So this includes citalopram or Celexa, escitalopram or Lexapro, fluoxetine or Prozac, paroxetine or Paxil, so sertraline, Zoloft, there's lots of them. Although the exact mechanisms behind depression and anxiety are not exactly known, SSRIs work on the basis that a contributor to these disorders are a lack of serotonin. So serotonin is a hormone or neurotransmitter that's responsible for modulating mood primarily, as well as things like cognition, reward, learning, memory, and feelings of happiness, which is obviously typically lacking in major depressive disorder. So in general, when the neurons in your brain are trying to communicate with each other, they release neurotransmitters into the space between the two neurons, known as the synaptic cleft right in here. These neurotransmitters go on to bind the next neuron, and this causes downstream effects. By inhibiting the reuptake of serotonin from the first neuron, this allows serotonin to stay for longer in the cleft and bind to the next neuron more frequently. And this allows for a larger effect in terms of happiness and mood. And therefore, that's how it's thought to help with things like major depressive disorder. So our next class of medications is quite similar. So serotonin norepinephrine reuptake inhibitors are another class of medication used to treat major depressive disorders and certain anxiety disorders. In some cases, SNRIs can also be used to treat very complex pain disorders as well. And they include medications such as desvenlafaxine, duloxetine or Cymbalta, and venlafaxine. Its mechanism is similar to SSRIs, except now it works on preventing the reuptake of two neurotransmitters. So it prevents the reuptake of serotonin, but also norepinephrine. And norepinephrine in the brain is responsible for increasing alertness and arousal. And this can be something that is lacking in major depressive disorder, for example. Essentially, at lower doses, they do act more like SSRIs, but at higher doses, the effects of norepinephrine come into play. And as a result, by preventing the reuptake, then they can bind for longer and create more feelings of happiness. And benzodiazepines are another class of medications that can be used for anxiety disorders. However, we don't typically use them as frequently anymore because there is a much higher chance of becoming dependent or addicted to them. So this includes medications such as alprazolam or Xanax, diazepam or Valium, as well as clonazepam or lorazepam, aka Ativan. So aside from anxiety disorders, they're more often used in seizure management and to stop someone from actively seizing. It's also used for insomnia as well as agitation, especially when it comes to psychiatric patients in hospital. And it works by enhancing the effects of GABA. And this is an inhibitory neurotransmitter that decreases activities of neurons. As a result, the neurons can't fire as often, and this leads to an overall calming effect. And so, for example, in seizure management, a seizure is literally a result of hyperexcitation of the neurons in a specific part of the brain. So it makes sense that this type of medication would be effective in that sense by literally reducing the activity of those neurons back to normal. And our last medication of today is our bisphosphonates, and these are a class of medication used to treat osteoporosis, as well as Paget's disease, which is another metabolic bone disease. And examples include risedronate, alendronate, and zoledronic acid. So osteoporosis is a disease that's caused by an imbalance in the amount of bone that's being broken down versus the amount of bone that's being built. So osteoclasts are the type of cell that's responsible for breaking down bone, and they're unfortunately overactive in osteoporosis. So bisphosphonates help treat osteoporosis by binding to a mineral in bone called hydroxyapatite and prevents osteoclasts from breaking down bone while also preventing them from even attaching to the bone. So as a result, bone doesn't break down as fast and you don't get some of those more negative downstream effects of osteoporosis, such as fractures. All right, and as always, we like to just put some helpful resources, and these slides will be available along with the recording on Dr. Gair's website. So for any medication questions, it's always best to ask your pharmacist or healthcare provider first, because again, there's multiple different factors that go in to choosing a specific medication. I found this Heart and Stroke website was really helpful for explaining those cardiac medications or the hypertension ones as well. So if those are ones you want to read more about, that can be a really great resource. HealthLink BC or 811 are always great as well to refer to, as well as Health Gateway can actually show you what medications you've been prescribed or have been dispensed. In case you're ever not sure or you want to refer back to what you used to have. In terms of if you want to look a bit more at certain things, Medscape is always a good, reliable resource. If you want a really technical explanation, StatPearls I found has been a really great website that I've referred to a lot for this presentation. And typically, yes, the WebMD, Mayo Clinic, Cleveland Clinic websites are also quite good as well. And we have a few more talks coming up this year. Next weekend, we have a talk on popular diets, and then we have 2 talks on stress. I'll give another talk on avoiding a drug interaction, and we'll wrap up with supplements. So we hope to see you there, and I hope you enjoyed this talk today and learned something. And if there's any questions, I'll take them now. Are there any questions? So yeah, can people on blood thinners still use aspirin? That's a great question. And again, that really has to do with what your specific situation is. So for example, when we talk about people who have received a stent in their heart, typically they will be on a combination of aspirin as well as either like clopidogrel or prasugrel or ticagrelor for at least a year. But again, that depends on your bleeding risk. And again, if you're really, really prone to clots, that might be an indication to go more the anti-clotting route. But again, it really depends on your specific situation. And it's definitely best to always double check with your doctor before starting aspirin. Oh, thanks for the great feedback, everyone. Are there any more questions? Or did anyone want to unmute or say something? All right. Well, thanks everyone for coming. We really appreciate your support. And yeah, if there's any questions, always feel free to email us. And hopefully we'll see you all next week, same time.